Welcome to the ASCO Update 2015 here in Zurich. Now we are going to discuss the practice-changing studies in haematological malignancies and other tumors. Next to me sits Professor Christoph Renner. He went through the relevant studies. Christoph, what has been presented in your field?
I think there were interesting abstracts, especially in the field of lymphoma myeloma. Now, if you ask me practice-changing, then I would say there was no practice-changing in lymphoma, including indolent, aggressive, and Hodgkin's lymphoma. We have seen a couple of trials with new drugs, but that is still to come. We have seen different sequencings of treatment, but again, it was not really practice-changing. So if I then move on from these entities to myeloma, I would say there were a couple of practice-changing trials presented for the myeloma. The first one I would like to mention is the ELOQUENT trial, the ELOQUENT-2 trial in relapsed refractory multiple myeloma. Patients had to have 1 to 3 prior treatments. And the new thing here is we do have lenalidomide plus dexamethasone as a treatment for relapsed refractory. And now the question was, if I add an antibody, in this case the elotuzumab, which is against the CS1, and nowadays we call it SLAM7 antigen, that the addition of this antibody to RD had a significant impact on progression-free survival without adding significant toxicity. So I think this antibody, and there was just a publication in the New England Journal of that trial, added to that established combo, will soon be a new standard in relapsed refractory multiple myeloma. And the other trial, the ENDEAVOR trial, was a direct comparison of bortezomib plus dexamethasone, again relapsed refractory multiple myeloma, and then the new arm was the second generation proteasome inhibitor carfilzomib in addition to dexamethasone. So the head-to-head comparison was VD Velcade Dex against KD carfilzomib Dex, and there was a significant improvement of PFS for the carfilzomib plus dexamethasone. Again, the drug is not approved yet in Switzerland, but we hope that we'll have it next year, and then that, I think, could be a new standard replacing bortezomib retreatment or new treatment in relapsed refractory multiple myeloma.
Now there were 2 studies presented in relapsed refractory myeloma patients. How do you sequence the treatments?
That's a good question. So, the advantage of the new proteasome inhibitor carfilzomib is it doesn't have any or very low rate of neuropathy, and it seems not to worsen neuropathy. So certainly if you had a patient first-line treatment with a proteasome inhibitor and he's not responding adequately anymore, I think the tendency is then to go for EMID, lenalidomide. So I think there the combination of elotuzumab plus lenalidomide is certainly interesting. If you probably had first line in EMID, lenalidomide, and then you would like to use a proteasome inhibitor, then now you will have the choice either bortezomib or carfilzomib. And the nice thing in the ENDEAVOR trial is there were patients included who had bortezomib already, and they were responding to carfilzomib. So you can actually make the sequence first generation proteasome inhibitor with bortezomib, and then you would still have the option of carfilzomib. So we don't really know what is the optimal sequence in relapse refractory, and I think it really depends on what have you used already, what is the toxicity, and certainly, it's a pricing issue there as well.
But I guess both are expensive.
They're both quite expensive. We don't know yet the price for the elotuzumab for the antibody. We certainly know it for RD. Bortezomib will come off patent soon, so it could be cheaper. The difficulty we have with carfilzomib is we don't really have an official pricing yet. And in every study, a different dosing is being used. So in the ENDEAVOR trial, there was a high dosing used of 56 milligrams per square meter. one of the first trials used for registration in US and Europe was 27 milligrams per square meter. So this is more than a doubling compared to the first trials. So it could make it quite expensive, but I think the company has to sort it out.
Okay, thank you very much.
Now we're going to other tumors. There was a really interesting presentation in the plenary session about advanced metastatic melanoma. Could you briefly summarize the findings of the study?
Yes, so at this year's ASCO, the late-breaking abstract number 1 was the Checkmate 067 study, which was a study in advanced metastatic malignant melanoma, first-line treatment, so untreated patients. And the question here was, what is the impact of checkpoint blockade treatment with the new antibodies? So it was a study, a 3-arm study, 945 patients, and there was an equal randomization to either ipilimumab plus placebo as a kind of standard arm, 4 doses. Then the comparator experimental arm was nivolumab plus placebo until progression, or the combination of both ipilimumab, 4 doses, plus nivolumab until progression every 3 weeks. And the dosing was a little bit adjusted, and the outcome was really that, first of all, tolerability was okay. We know the toxicity of IPI, primary pneumonitis, colitis, etc. There was a slight addition of toxicity when you combine both antibodies. And the outcome was pretty much as expected, long-term remission, 20-25% for the IPI alone, and that was significantly increased by the addition of nivolumab to IPI, and that curve seems to run at 45-50%. And the nivo alone was a little bit lower, but still seems to be significantly better than the IPI alone.
Now I guess this is new standards in all those patients who do not have a BRAF mutation, correct?
Well, it was both. In that trial it was BRAF wild type, but there were other trials where it was shown that the drugs work irrespective of BRAF mutation status. So you certainly have the tyrosine kinase inhibitors for BRAF mutated malignant melanoma, but it is not that you should strictly separate the two, the one only with antibodies and the other ones with TKIs. I think the whole field will merge, and there were articles actually combining the two classes of drugs with the question. So I think the advantage of the checkpoint blockade inhibitor antibodies is that it seems to be that we see long-term remissions with a plateau. The advantage but you don't see a significant increase always in PFS. The advantage of the TKIs is you see a shift in PFS with nice remissions, but you don't see a long-term efficacy. So these trials, where they combined both, they were hoping shift of PFS with increase in long-term survivors. But that was not studied in that trial. I think the important thing we can learn from this Checkmate trial was a sub-analysis where they looked which patients actually benefited from the nivo arm alone or which ones needed the combination. There it seems if you have a certain threshold of PD-1 ligand expression, ligand 1, on the tumor cells, that nivo alone gives you a very nice durable response. If you don't have PD-L1 expression at a sufficient level on tumor cells, it seems that the combination of IPI plus nivo is the one you need. So probably or hopefully we will have a biomarker in the future which tells us, do I need the combination with more toxicity or is nivo alone sufficient? But the IPI alone, I think that will be replaced in the future.
Christoph, thank you very much for the nice presentation and summary of these practice-changing studies.
Thank you.